So hi friends, in continuation with the OSCE series. So this would be the first case in the Neuro-Radiology OSCE series. So let's start with the case. So this is the relevant history which has been provided to you. A 7-year-old male child presented with complaints of headache, vomiting, difficulty walking, and loss of equilibrium, uh, with a duration of complaints extending from a period of about 3 to 4 weeks. No episodes of fever were reported. The patient was referred for an urgent MRI brain in our department. So these are the images which have been provided to you. You can pause this video, okay, and try to analyze the images. Okay, so these are the first two images, and two more images have been provided to you. Okay, now these are the questions which have been asked. Okay, so first of all, you have to identify all the sequences, and then you have to give the diagnosis. You have to tell them what is the most common location of this lesion in the brain. You have to name two differentials, and also you have to mention the new molecular subtypes of the aforementioned lesion. So let us look at the answers. The diagnosis is obviously medulloblastoma. The order of the images which have been provided to you are the image A was your T2 weighted images. Okay. B was your T1 weighted images. The C1 was your diffusion section imaging, and the D1 was your post contrast T1 weighted imaging. Okay. So the most common location of the medulloblastoma is your posterior fossa in the brain parenchyma, and in the posterior fossa, the most common location is the cerebellum, and in the cerebellum, the most common location is your vermis. The two differentials of the medulloblastoma in this location specifically are your ependymoma and your atypical teratoid rhabdoid tumor. If a medulloblastoma in the cerebellar hemisphere would have been demonstrated, then the pilocytic astrocytoma would also have come into the differentials. So the molecular subtypes, so the latest one are your according to the 2021 WHO classification. These are your WNT activated, SHH activated, non-WNT, non-SHH, and all the 2016 classification medulloblastomas, which were based on the histological types, have been now grouped into a single category, which is your medulloblastoma histologically defined. Okay, so these consist of your four medulloblastomas. One is your classic or the classical medulloblastoma, which is the most common, and this is about 70% of the cases. Next is your desmoplastic or nodular. Third is your medulloblastoma with extensive nodularity. And the fourth one is your large cell or anaplastic medulloblastoma. Okay, so this was on the basis of 2016 histological classification. But now, according to the 2021 WHO classification, they have been grouped into a single category, which is your medulloblastoma histologically defined. Okay, and these are the rest of the three categories according to the 2021 WHO classification. Now, let us discuss this case in detail. Okay, so first of all, you should be knowing about the sequences. This is a very common question, okay, which is asked. And also, whenever you are, suppose this case is coming you as a short case, okay, the sequences will not be labeled on the films. So you have to identify the sequences. So try identifying the sequences in your day-to-day reporting. Okay, don't just try to see the name or the heading which has been given under the image. Try to identify the sequence yourself. Okay, so this is a T2 weighted sequence, the image A. B is a T1 weighted sequence. C is your diffusion section imaging. And D is your post contrast T1 weighted imaging. Okay. Now you can see that there's a altered signal intensity lesion. It's a midline lesion. Okay. Uh, it is epicentered in the region of the fourth ventricle. What is the signal intensity on different sequences? It's hypointense to the cortex on T1 weighted images. On T2 weighted images, it is heterogeneously hyperintense with few cystic areas also. You can visualize. It shows avid diffusion restriction. There's a low signal on ADC and high signal on DWI. And the fourth image is a sagittal post-contrast image. which shows heterogeneous enhancement. Okay. So if you summarize the findings, you see a midline altered signal intensity lesion, which is epicentered in the fourth ventricle, causing its expansion. Okay. It's hyperintense on T1 weighted images, heterogeneously hyperintense on T2 weighted images, shows diffusion section on DWI-ADC images, heterogeneous enhancement on post-contrast images. Then we have a cystic or necrotic component, which we can visualize. Okay. Other findings, what we can see here is it's compressing the brainstem anteriorly, and there is prominence of the supratentorial ventricular system. So these are the two additional findings. Okay. So the clue or the most important finding is number one, it's a midline mass, first of all, very important. It's epicentered in the fourth ventricle, very important. And the most important point is your low signal intensity on ADC images. That is your avid diffusion section. Okay. So these three images will give us or will lead us to your diagnosis of medulloblastoma. Let us discuss in detail about the medulloblastoma. Then we'll discuss about the differentials, how to differentiate those differentials, and we'll end the class by having an approach to the posterior fossa tumors, a simplified basic approach to the posterior fossa tumors. Okay. So 2 points you have to remember about medulloblastoma is that, first of all, it's a most common malignant brain tumor of the childhood. And if we say it's a overall pediatric tumors, if we say it's a second most common overall pediatric tumor, the first most common is your astrocytoma. But if the question is most common malignant brain tumor of childhood, that is your medulloblastoma. Okay. Most commonly, it will present as midline masses. Okay. In adults, it usually present as lateral masses or eccentric masses, but in children, it will most often it will present as midline masses, where in the roof of the fourth ventricle, in the region of superior medullary velum. Okay. All these points you have to very carefully remember. Okay, because these all points will help you differentiate the medulloblastoma from its close differentials. Okay, the peak incidence again of the age is very important. Okay, that's one of the factors that will differentiate it from the ATRT tumors. Okay, that's from the peak incidence is between 3 to 7 years of age, but you can get medulloblastomas even up to the age of 12 years as well. Okay, so more common in females. Okay, all of the medulloblastomas, be it any category, they are now considered grade 4 tumors. And the OSCE-1, it puts it as a part of embryonal neoplasms. So if you're studying OSCE-1, okay, you will get medulloblastoma under the category of embryonal neoplasms. Okay, so it has divided the tumors into three categories. One is your medulloblastoma, one is your non-medulloblastoma embryonal tumors, and third one is your ATRT tumors. Okay, this is a classification which is used in the OSCE-1. Let us look at the location. I told you the most common location is your cerebellum, and inside the cerebellum, 75% you will see in the region of vermis. So that is why they are the most commonly they will present as midline tumors. They will tend to protrude into the fourth ventricle from its roof and may even grow directly into the brainstem. Okay. This is the most common pattern which is seen in your group 3 and group 4 tumors. Okay, I'll explain you what is group 3 and group 4 when I'll discuss the molecular classification of medulloblastoma. For now, just remember that uh, the most common location is your vermis. Okay, and if they are present in the vermis, they tend to protrude into the fourth ventricle from its roof and may even grow directly into the brainstem. So this is the most common pattern, and this is the most common pattern which is visualized in group 3 and group 4 tumors or medulloblastomas. Okay, so in day-to-day imaging, whatever the most common pattern what we see will be your group 3 and group 4. Okay, laterally in the cerebellar hemisphere, I told you that is less common in children and more common in adults. And the subtype or the molecular subtype where the location is much more lateral in the cerebellar hemisphere, they are your SHH activated. Okay, and if the location is in the cerebellar peduncle, its epicenter is in the cerebellar peduncle. Okay, the most common molecular subtype which is associated with it is your WNT activated. Okay. I'll explain you how to predict the molecular subtype based on the imaging in the coming slides. Okay. So for now, this is the slide just to tell you that the locations can be in the cerebellum. Okay, that's the most common one. In the cerebellum, the most common is the vermis. Next, then they can also be seen in the lateral cerebral hemisphere. They can also be seen as a part of the epicenter in the cerebellar peduncle as well. Now, let us look at two classifications. Okay. The 2016 WHO classification divided it on the basis of histology. I've already told you four types: classical, desmoplastic, the medulloblastoma with extensive nodularity, and your large cell or anaplastic. And all of these are considered WHO grade 4 neoplasms. But the current classification, what we use is your 2021 classification. This is based on a molecular subtypes. Okay. These two I've already told you. Okay. The non-WNT, non-SHH, they consist of two groups, group 3 and group 4. And the fourth one consists all your histological classifications. Okay. Very simple, nothing complex in this. Now we should be knowing few points about each and every type of medulloblastoma. Okay, so let us start with your classic medulloblastoma. Okay, so these are 70% of all the cases of medulloblastoma. Okay, since the most common location is the vermis, so 85% of these will be seen in the midline. These represent all molecular subtypes. Okay, so all molecular subtypes can be classical medulloblastomas as well. Okay, they are located within the fourth ventricle, epicentered in the fourth ventricle, and they may focally infiltrate into brainstem and vermis. And sometimes they can be presenting as a diffusely infiltrating lesion with a focal dominant mass. Okay, so sometimes they can present to you as a discrete lesion, like in our case, but sometimes it can be a diffusely infiltrating lesion also. Okay, okay, without any focal dom or okay, without any discrete mass. Okay, uh, again, two very important points, or which is your differentiating point from other differentials, is that the posterior inferior extension to the cisterna magna is common. Okay, however, it does not extend does not extend into the CP angle region or foramen of Luschka. Okay, please remember this is one of the differentiating points from ependymoma. Okay. Foraminal spread. What is foraminal spread? That is extension into the foramen of Magendie and Luschka. That is seen with ependymoma. That is not seen with medulloblastomas. Okay. So extension into the cisterna magna is common. However, extension into the CP angle region or foramen of Luschka is not seen with medulloblastomas. Okay. The only medulloblastoma which can show you a foraminal spread very rarely is your medulloblastoma, which is epicentered in the cerebellar peduncle, which is your WNT pathway activated medulloblastoma. Since it has an epicenter in the cerebellar peduncle, it can extend to CP angle or foramen of Luschka. Rest all of the medulloblastomas will never extend into the CP angle or foramen of Luschka. Okay. Now, since it's the most common type of medulloblastoma, okay, which we see on imaging, so we should be familiar with the imaging features of the classical medulloblastoma. Okay, since it's a small round cell tumor, there are many densely packed round cells are there, so it will be hyperdense on CT. Okay, it's a midline posterior fossa mass that we all know. Okay, cyst formation is common. It's about seen in about 40 to 60% of the cases. Okay, calcification is uncommon. Okay, seen in only about one third of the cases. Hemorrhage is very rare. Okay, you will never see a hemorrhage in cases of medulloblastoma. Okay, and CCT will obviously show you heterogeneous enhancement. Okay, one big point here is your medullostomas can be associated with many syndromes. Okay, one of the syndrome is your Gorlin, or what we know it by the other name, that is your basal cell nevus syndrome. Okay, so you have a medulloblastoma. Along with that, you have dense tentorial, or falcine calcifications. Okay, so you can evaluate the patient for basal cell Nevo syndrome or Gorlin syndrome. Okay, so that was one of the clues. Along with medulloblastoma, if there is some association with the syndrome, you will get dense tentorial or falcine calcifications. Okay, so let us look at the MRI findings. Okay, most of these we have already seen in our patient. So it's hypointense to gray matter on T1 weighted images. It's heterogeneously hyperintense on T2 weighted images. The pick point or the click point here is your low signal on ADC. That is a differentiating feature from the rest of the differentials. Okay, so what is the ADC value? That's lower than that of the normal cerebellum, which is 515 to 10 raised to power minus 6 mm square per second. Okay. Uh, Perirenal edema is usually uncommon, seen in only one third of the cases. And if it is able to obstruct the completely efface the fourth ventricle decay, so it can lead to supratentorial obstructive hydrocephalus as well. Okay. But the differentiating feature here is your low value on ADC images that you should remember. So the enhancement pattern on MRI, 90% of the medulloblastomas will enhance. Okay. The most common pattern of enhancement in medulloblastomas is your heterogeneous enhancement. Okay. And then there can be two other types of enhancement as well. If the tumor is homogeneously enhancing, it is vividly enhancing, it's usually a molecular subtype of WNT activated. And if the medulloblastoma shows minimal enhancement, it's usually a group 4 molecular subtype. Okay. Now, how do you predict the imaging on predicting basically the molecular subtype from imaging? Okay, so it consists of two things, 2 points. One is your location, the other one being basically your enhancement. Okay, and then we have the based on the molecular subtype, we have different types of prognosis as well according to the molecular subtype. If the location or the medulloblastoma is epicentered in the region of cerebellar peduncle or the foramen of Luschka, I told you it's a very rare type. It's a WNT activated type, and it has the best prognosis out of all the medulloblastomas. If it's epicentered in the cerebellar hemisphere, I told you it's usually seen in adults and in SHH activated molecular subtype. And on the histological basis, it would most likely be a desmoplastic or a nodular medulloblastoma or a medulloblastoma with extensive nodularity. It has intermediate prognosis. Now, moving on to the most common location, which is your midline. Okay. Now there can be two types. Okay, so midline, I told you it's either it's group 3 or group 4. So on the most common basis, the type of medulloblastoma which you will be getting in pediatric age group will be your either group 3 or group 4 molecular subtype. If it's in the age group is that of an infant, the patient has or the tumor has ill-defined margins, it has prominent enhancement, it usually would be a group 3 tumor and would be having the worst prognosis out of all the medulloblastomas. And if it's like a toddler in the age group of 3 to 7 years, the tumor has well-defined margins. Tumor has usually mild or minimal enhancement. It's usually a group 4 tumor and it has about intermediate prognosis. Okay, so this is how you predict the molecular subtype on the basis of imaging. That is two things. One is your location, other one being your enhancement. Okay. Now, we should be knowing in brief about the imaging features of the rest of the histological types of medulloblastoma. Just one table, okay, and the most important points. Okay. Now, the first one being your medulloblastoma with extensive nodularity. So as the word nodularity is there itself in the name, so there will be multifocal grape-like tumor masses. Okay, so there will be multifocal grape-like tumor masses which will be enhancing strongly and uniformly. Okay, so there will be a cystic component, and inside that there will be multiple enhancing nodular masses. Okay, okay, so there will be a cystic mass lesion with multiple enhancing nodular masses within. Okay, giving a grape-like appearance. Okay. Two other important points being it's almost exclusively seen in infants and it's usually an off midline or a para midline mass. It's usually not a midline mass. Talking about the desmoplastic or nodular type, again, it's most commonly seen in infants and 90% of them are your SHH activated. These are again midline masses. Okay. It's usually difficult to differentiate, but there will be much more cystic areas in desmoplastic or nodular type of medulloblastoma in comparison to your classical medulloblastoma. Okay, so there will be multiple peripheral small cysts and focal areas of T2 flare hyperintensity that enhance. Okay, large cell or anaplastic has no such distinctive imaging features. Okay, it will show significant but inhomogeneous enhancement on post-contrast images. Okay. There are no differentiating features as such of the large cell or anaplastic medulloblastoma. Okay. Two types of METs, which are very commonly seen with medulloblastoma. Number one are your drop METs, and other is your leptomeningeal spread. Okay, so these two are very commonly seen. Okay. Since the drop METs are very common with medulloblastoma, so if you get a case of medulloblastoma, you should always screen the spine for drop METs. Okay, always and always screen the spine for drop METs. Okay, so you will be seeing them as enhanced circumscribed nodules with irregular thick enhancement along the dorsal spine. Now, so whenever you study the differentials, okay, the differentiating features are the most important to be remembered. Okay, so the first differential in our case, since it's a midline mass, that will be ependymoma. The ependymoma, the origin of location is from the lateral recess of the fourth ventricle or midline 4 of the fourth ventricle near the orbix. Okay. The most important feature is it always extends to the foramen of Luschka and Magendie. So that is why there's a term which we call it as the plastic ependymoma, which has been given to this because of its extension through the foramen of Luschka and Magendie. The calcifications are very common. They are seen in about half of the cases of ependymoma. The other important, the differentiating feature is that the ADC value is intermediate. It is not as low as the medulloblastoma. Okay, so you get a midline mass, which you see extending it through the foramen of Luschka and Magendie. You see good amount of calcifications within. You see good amount of hemorrhage also. Okay, so hemorrhage is also one of the features. Okay, so hemorrhage and calcifications are very common in ependymoma, although they are very uncommon in medulloblastoma. Okay. So the other features, just to complete the list, we have cystic areas, we have solid component, we have heterogeneous enhancement. So these are overlapping features, not any differentiating points. Differentiating is one is through the foraminal spread, through the Luschka and Magendie foramens, extensive calcification and hemorrhage, intermediate ADC value. Okay. Since you have calcification and hemorrhage, so you will see blooming on susceptibility weighted imaging. So let us look at one of these cases. You see a large intraventricular mass. Okay. So the important thing which you see that is seen extending into the bilaterally into the foramen of Luschke. Okay. And there's also extension to the foramen of Magendie as well. Okay. A little bit cranial picture has been taken, but you can easily see the extension through the foramen of Luschke. Okay. The next differential being your atypical teratoid and rhabdoid tumors. Again, the most common location for these is your cerebellum. Okay. Again, you should be knowing about the differentiating points. These are usually large heterogeneous masses. Okay. They are extremely heterogeneous, even more heterogeneous than medulloblastomas. And the age group is your very young children. Okay. That is before the age of 3 years and newborns. Okay, so there is some literature which says that they are almost exclusively found in newborns. Okay, so you will say that about 80 to 90% of the cases of ATRT tumors, okay, you will diagnose them at birth itself. Okay, so they will be diagnosed at birth itself. So they're almost exclusively found in newborns. And if you go to the children age group, that is before the age of 3 years. Medulloblastoma, the peak incidence is 3 to 7 years. ATRT before 3 years, but 80 to 90% cases newborns. Then we have significant areas of hemorrhage also, which is seen in ATRT. Hemorrhage is very uncommon in cases of medulloblastoma. So large heterogeneous masses, newborns, significant areas of hemorrhage. Okay, so these are the 3 points which you should be remembering about ATRT as a differential to differentiate it from medulloblastoma. Okay, so this is one of the cases of ATRT. You see, it's an extremely heterogeneous tumor. We have cystic CSF densities within. Okay, and then we have these are the T2 hyperdense areas, which are actually areas of hemorrhage. Okay, and again, it's a midline mass. Okay, epicentered in the fourth ventricle. Now, this is an approach. Just to complete the class, if you get any posterior fossa tumor in a pediatric age group, how to approach in a simplified manner. Okay, how to approach the diagnosis in a simplified manner. Okay, so if you get a posterior fossa tumor, there can be four locations. Okay, so the first thing is you have to decide upon the location. Okay, you have to decide upon the location. What is the location of the tumor? Is it in the cerebellar hemisphere? Number one. Is it in the brainstem? Okay, it's in the fourth ventricle, or it's in the foramen of Luschka or the CP angle region. Okay. What we are concerned about here is these three things. One is your cerebellar hemisphere, fourth ventricle, and your foramen of Luschka. Okay. Brainstem. I'll we'll have some separate case for this. Okay. I'll be having you with a brainstem or a pontine glioma, and then we'll study the approach to the brainstem posterior fossa pediatric tumors. But right now, what we are concerned here is about these three locations. Let's start with the cerebellar hemisphere. So the first thing what we need to look upon is your location. The second very important point is your ADC values. Okay. So for differential diagnosis, two things are very important. First, you have to decide what is the epicenter of the tumor or the lesion. And next thing, just look at the ADC maps. If it has low ADC value, means it is showing good diffusion restriction. Okay. Check the nature. If the tumor is looking almost like extraaxial, it's a medulloblastoma in the cerebellar hemisphere. What is the molecular subtype which is associated with the uh, basically the cerebellar hemisphere or the paramidline location? That is your SHH activated. Next, if it's a extraaxial tumor, plus it also shows enhancing nodules. So it's a desmoplastic or a nodular type of medulloblastoma. Okay. Again, the most common molecular subtype which is associated with the desmoplastic or the nodular type is your SHH activated. Okay. Now, I told you that if the medulloblastoma is in the cerebellar hemisphere, means it's not in the midline, it's in the it's in a off midline or a paramidline location, then the pilocytic astrocytoma will come as a differential. But if it's in the midline, the two differentials which will be coming are your ependymoma and your ATRT tumors. Okay. For midline fourth ventricle masses, pilocytic astrocytoma is not a differential. Okay. So please remember. So this is a very good and a simplified approach. Okay. So we are done with the low ADC in the cerebellar hemisphere. Let's move on to the high ADC. There's just one differential, obviously, which is there in the pediatric age, which is your pilocytic astrocytoma. Okay. So it will be showing you solid with intervening cystic areas. Okay. So very simple. Okay. So cerebellar hemispheres, depending on the ADC, low ADC and high ADC, low ADC, extraaxial without nodules, uh, medulloblastoma SSH activated. Uh, that is a classical medulloblastoma. If it's extraaxial plus it shows enhancing nodules, it's a desmoplastic or a nodular medulloblastoma. If the ADC is high, means there is no diffuse restriction, and we have solid or cystic areas also, then it's a pilocytic astrocytoma. Now, if it's epicentered in the fourth ventricle, again, the main point here would be again to look at the ADC values. If it's showing diffusion restriction, okay, that is your low ADC values. If the age is less than 3 years and the tumor is not enhancing, okay, or it shows minimal heterogeneous enhancement, it's usually a group 4 medulloblastoma, or it can be ATRT also. I've told you for ATRT, okay, you will find significant areas. Then you will, for differentiating these two, you will go to other features also. The enhancement will be much more in cases of ATRT. There will be significant areas of hemorrhage also. Okay. Then we have multiple enhancing nodules. Okay. Again, it's a desmoplastic or a nodular type of medulloblastoma. The molecular subtype associated with this is your SHH activated. Okay. And this is the most common pathway which you get in day-to-day practice. Tumor, posterior fossa tumor, epicenter in the fourth ventricle, low ADC values, age group of more than 3 years, showing heterogeneous enhancement on post-contrast images. It's your classical medulloblastoma. And I told you the classical medulloblastoma defines all the molecular subtypes. Okay. Next, obviously, you have a fourth ventricle mass, which shows either high ADC or intermediate ADC values with cystic, hemorrhagic, and calcific areas. What is the diagnosis? It's your ependymoma. Okay. So it's your ependymoma. Okay. 50% will show calcifications. Significant amount of tumors will show hemorrhagic areas. The cystic component is also seen in about 50% of the cases. Epicenter in the fourth ventricle, no diffusion section. It's your ependymoma. Next is finishing off with the location at the foramen of Luschka. I told you the foramen of Luschka is the most common location for ependymoma, but one of the medulloblastomas molecular subtype WNT activated, which is epicentered in the region of the cerebellar peduncle, can also extend into the foramen of Luschka and the CP angle region. Okay. Again, what you will look is your ADC values. If it's again high or intermediate with cystic, hemorrhagic, calcific areas, no confusion, it's an ependymoma. But if it shows diffusion restriction, that is your low ADC values, go towards the age group. If it's less than 3 years, it would most likely be an ATRT tumor. And if the age group is more than 3, it would most likely be a medulloblastoma of the molecular subtype WNT activated. Okay. So I hope you're clear with the simplified approach to the posterior fossa tumors based on the location and ADC values. This is just a table which summarizes the most important differentials, okay, of medulloblastoma. Okay. You can learn this and replicate this in your exams if you get a question on medulloblastoma. Okay, I'll just be discussing you about the important points. Site, I told you, medullo and ependymoma, they are both midline masses, while pilocytic astrocytoma is an eccentric, or because it's located in the cerebellar hemispheres, so it's a off midline mass. Okay, the word which you use is off midline, okay, or what we call it as hemispheric. Okay, very important point, ADC values. The highest level of diffusion section will be shown by medulloblastoma, intermediate ADC values in ependymoma, and high ADC values, that is no diffusion section in pilocytic astrocytoma. Foraminal spread, what is foraminal spread? That is spread in the region of foramen of Luschka and foramen of Magende. Only one tumor will show you, that is ependymoma. And if it's a medulloblastoma which is showing foraminal spread, that would only be a WNT activated medulloblastoma. Okay. Then subarachnoid seeding, which is your leptomeningeal spread, and along with that your droppments. They are very common and extremely important with medulloblastomas. Okay. These are very uncommon and rare with ependymoma and astrocytoma respectively. Okay. So we have a patient with a midline posterior fossa mass and you get droppments. It is definitely medulloblastoma. It cannot be anything else. Then MRS usually doesn't play a very important role. Okay. But if you have, you can apply that and you can take note of these metabolites, but they are usually not very important. Okay. The points which are labeled in the red, they are the most important differentiating features which you should remember in your exams, at least in your practical exams. Okay. So this was all about the today's OSCE. Thank you.